Block Simulation 17. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. What is the diagnosis and inheritance pattern? A 6-year-old boy presents with a swollen, painful knee after a minor fall and a history of prolonged bleeding after circumcision. His maternal uncle had a similar bleeding tendency. Labs, PR prolonged, PTT, normal PT, normal platelet count, and normal bleeding time. A mixing study corrects the PTT. Factor assay shows low factor VA activity. Read the command, diagnosis, and inheritance. Homarthrosis, prolonged PTT with normal PT, low factor 8, maternal uncle affected. Hemophilia A, X, linked recessive. This is hemophilia A, a deficiency of clotting factor 8. Factor 8 is part of the I intrinsic pathway, so its deficiency prolongs the PTT, while the PT extrinsic pathway stays normal. The platelet count and bleeding time are normal because primary hemostasis is intact. The problem is the coagulation cascade. So patients have deep bleeding, hemarthrosis, the swollen knee, muscle hematomas, and prolonged bleeding after procedures. A mixing study corrects, confirming a factor deficiency rather than an inhibitor. The correct answer is A. The inheritance is X-linked recessive, which is why it affects males and is transmitted through carrier mothers, explaining the affected maternal uncle. Hemophilia B is the same clinical picture but from factor IX deficiency. Contrast with von Willebrand disease, which prolongs the bleeding time and causes mucosal bleeding primary hemostasis. The factor 8 deficiency with isolated PTT prolongation and X-linked inheritance is hemophilia A. What primarily determines pulse pressure, and why is it wide in here? A physiologist measures a patient's blood pressure as un-1670 mmHg, giving a wide pulse pressure of 90 mmHg. The patient is an elderly man with stiff, non-compliant arteries. Read the command, what determines pulse pressure and why widened. Pulse pressure, stroke volume, arterial compliance, stiff arteries widening. Pulse pressure is the difference between systolic and diastolic pressure. It is determined primarily by two factors, stroke volume and arterial compliance. Pulse pressure is proportional to stroke volume divided by compliance. A larger stroke volume ejected into the aorta raises the systolic pressure and widens pulse pressure. And stiffer, only assess compliant arteries, as in this elderly patient with arteriosclerosis. Cannot stretch to buffer the ejected volume, so systolic pressure rises sharply and diastolic falls, widening the pulse pressure. The correct answer is D. This explains the clinical patterns. A wide pulse pressure occurs with decreased compliance, aging, atherosclerosis, high stroke volume states, aortic regurgitation, and hyperthyroidism. A narrow pulse pressure occurs with low stroke volume, aortic stenosis, heart failure, cardiac tamponade, and hypovolemic shock. The elderly patient's stiff, low compliance arteries widening the pulse pressure illustrates the compliance factor. A deficiency of which vitamin, an antioxidant, best explains the hemolysis and neurologic findings. A child with cystic fibrosis and chronic fat malabsorption develops a hemolytic anemia and progressive neurologic problems. Ataxia, loss of proprioception and vibration sense, and areflexia, resembling a spinocerebellar degeneration. Other fat-soluble vitamin levels are also low. Read the command, which vitamin? Fat malabsorption, hemolytic anemia, neurologic degeneration, ataxia, posterior column signs, antioxidant, vitamin E deficiency. Vitamin E, tocopherol, is a fat-soluble antioxidant that protects cell membranes, especially the lipid-rich membranes of red blood cell membranes are oxidatively damaged by free radicals. Deficiency, usually from fat malabsorption, cystic fibrosis, cholestasis, abetalipoproteinemia, causes two main problems. First, a hemolytic anemia, because unprotected red cell membranes are oxidatively damaged. Second, neurologic degeneration that resembles spinocerebellar ataxia and posterior column disease. Ataxia, loss of proprioception and vibration sense, and areflexia, because neuronal membranes are similarly damaged. The correct answer is E. The neurologic picture of vitamin E deficiency can mimic that of vitamin B12 deficiency. Both affect the dorsal columns and cause ataxia. But vitamin E deficiency does not cause megaloblastic anemia. It causes a hemolytic anemia, and there are no hypersegmented neutrophils or megaloblastic changes. The antioxidant role explaining both the hemolysis and the spinocerebellar posterior column neurologic findings points to vitamin E. Which cranial nerve is affected, and why is it vulnerable to raised intracranial pressure? A 45-year-old woman with elevated intracranial pressure from a brain tumor develops horizontal double vision. On exam, her right eye cannot ABDUIT move laterally past the midline, and she has esotropia. The eye turns inward at rest. All other eye movements are intact. Read the command, which cranial nerve and why vulnerable to ICP? Inability to abduct, esotropia, raised ICP. CMVI abducens palsy, long course, false localizing sign. The affected nerve is cranial nerve BI, the abducens nerve, which innervates the lateral rexus muscle, the muscle that abducts the eye. When it is paralyzed, the eye cannot move laterally past the midline, and the unopposed medial rectus pulls the eye inward, esotropia, causing horizontal diplopia. CNVI is especially vulnerable to raised intracranial pressure because it has the longest intracranial course of the cranial nerves and travels up along the clivus, where increased pressure stretches and compresses it. The correct answer is C. Because raised intracranial pressure from any cause can produce a sixth nerve palsy, it is called a falsely localizing sign. The palsy does not indicate that the lesion is near the nerve itself, just that pressure is elevated somewhere. Recall the eye muscle innervation rule, LR6SO4, everything else. 3. Lateral rectus is CN6, superior oblique is CN4, all the rest are CN3. The inability to abduct from a CNVI palsy, vulnerable to ICP via its long course, is the answer. What is the underlying pathophysiology? A 45-year-old man presents with several months of difficulty swallowing BOTH solids and liquids from the start, regurgitation of undigested food, and weight loss. A barium swallow shows a dilated esophagus that tapers to a bird's beak at the lower esophageal sphincter. Manometry shows incomplete LES relaxation and absent peristalsis. Read the command, underlying pathophysiology. Dysphagia to solids and liquids, bird's beak, absent peristalsis, incomplete LES, relaxation, achalasia, loss of myenteric inhibitory neurons. Atalasia results from the LOS of inhibitory ganglion cells in the mentoric Auerbach plexus of the esophagus. These neurons, which release nitric oxide and VIP, are needed for the lower esophageal sphincter to relax and for normal peristalsis to propagate. Without them, the LES fails to relax, stays tight, and the esophageal body loses peristalsis. The result is functional obstruction at the gastroesophageal junction. Food and liquid cannot pass, so the esophagus above dilates, producing the classic bird's beak, tapering on barium swallow. The correct answer is E. A key diagnostic clue is that dysphagia occurs with BOTH solids and liquids from the onset, pointing to a motility problem rather than a mechanical obstruction, which typically causes progressive dysphagia to solids first. Secondary achalasia can be caused by Chagas disease, Trypanosoma cruzi, destroying the plexus. There is also an increased risk of esophageal cancer. The loss of inhibitory, myenteric ganglion cells impairing LES relaxation and peristalsis is the pathophysiology of achalasia. Which renal mechanism is the most important for increasing net acid excretion in chronic acidosis? A patient with a chronic metabolic acidosis must excrete the daily acid load. The kidney regenerates bicarbonate and excretes hydrogen ions buffered in the urine. A key adaptive mechanism increases over days. Read the command. Most important mechanism for net acid excretion in chronic acidosis. Increased renal ammoniogenesis. The kidney excretes acid in two buffer forms, titratable acid, mainly phosphate, and ammonium. While titratable acid is relatively fixed by the amount of filter phosphate, the ammonia system is the adaptive one. In chronic acidosis, the proximal tubule cells I and C increase production of ammonia from glutamine renal ammonogenesis over several days. The ammonia, NH3, is secreted into the tubule, traps a hydrogen ion to become ammonium NH4+, and is excreted in the urine. Each ammonium excreted allows the kidney to regenerate a bicarbonate. This adaptive increase in ammonia production is the main way the kidney ramps up net acid excretion. The correct answer is C. The reason ammoniogenesis is the key adaptive mechanism is its capacity to increase several-fold over days, vastly expanding the kidney's ability to excrete acid, whereas titratable acid is limited by filtered buffer. This is why the renal response to a chronic acid load takes days to fully develop. Increase renal ammoniogenesis buffering and excreting hydrogen ions while regenerating bicarbonate is the most important mechanism. What is the mechanism of this drug, and where does it act? A 50-year-old man with heart failure and resistant hypertension is started on spironolactone in addition to his other diuretics. Months later, he develops painful gynecomastia and a slightly elevated potassium. Read the command, mechanism, and site of spironolactone. Aldosterone receptor antagonist in the collecting duct, potassium sparing, gynecomastia. Spironolactone is a potassium-sparing diuretic that works as a competitive antagonist of the aldosterone mineralocorticoid receptor in the principal cells of the collecting duct. Aldosterone normally promotes sodium reabsorption through ENaC and potassium and hydrogen secretion. By blocking the aldosterone receptor, spironolactone causes mild sodium and water loss while retaining potassium, hence potassium sparing, which is why it can cause hyperkalemia. It is used in heart failure, where it has a mortality benefit, resistant hypertension, hyperaldosteronism, and cirrhotic ascites. The correct answer is E. The painful gynecomastia is a classic spironolactone side effect because it also has anti-androgenic activity. It blocks androgen receptors and affects steroid synthesis. Eplerenone is a more selective aldosterone antagonist that causes less gynecomastia. The other potassium-sparing diuretics, amiloride and triantarene, block ENaC directly rather than the aldosterone receptor. The aldosterone receptor antagonism in the collecting duct, sparing potassium with antiandrogenic gynecomastia, identifies spironolactone. What is the diagnosis? A 60-year-old man presents with chronic, itchy, scaly erythematous skin patches and plaques that have slowly progressed over years, now with some thickened tumors. Skin biopsy shows an infiltrate of atypical CD4+ T lymphocytes in the epidermis forming small clusters, or potrier microabscesses. Later, atypical lymphocytes with cerebriform nuclei appear in the blood. Read the command, diagnosis, chronic scaly patches plaques tumors, CD4 T cells in epidermis, potrier microabscesses, cerebriform cells in blood, mycosis fungoides, Sézary syndrome. This is mycosis fungoides, a cutaneous T-cell lymphoma, a malignancy of mature CD4-positive helper T lymphocytes that home to the skin. It progresses slowly through stages over years, flat patches, then raised plaques, then nodular tumors, often itchy and mimicking eczema or psoriasis early on. The diagnostic histology shows the atypical T cells infiltrating the epidermis and clustering into potrier microabscesses when the malignant cells spread into the blood, producing circulating atypical lymphocytes with characteristics cerebriform of brain-like grooved nuclei, the Sézary cells with diffuse erythroderma. It is called Sézary syndrome. The correct answer is A. The two defining microscopic clues are the potrier microabscesses, T cells clustered in the epidermis, and the cerebriform nuclei of the Sézary cells. Mycosis fungoides is the skin-limited form, Sézary syndrome is the leukemic, erythrodermic form with blood involvement. The chronic, slowly progressive skin patches with epidermal CD4 T-cell infiltration and cerebriform cells in the blood point to cutaneous T-cell lymphoma. What is the mechanism of the toxin? A traveler returns from an area with poor sanitation and develops profuse, watery diarrhea described as rice water stool, with no blood, leading to rapid, severe dehydration. Stool culture grows a comma-shaped, oxidase-positive gram, negative rod that is motile and grows in alkaline media. Read the command mechanism of the toxin. Rice water stool, comma-shaped oxidase, positive gram, negative rod, alkaline media, Vibrio cholerae, cholera toxin activating Gs and raising CAM. Vibrio cholerae produces cholerae toxin, which causes a profuse secretory diarrhea. The toxin permanently activates the G-stimulatory G protein by ADP ribosylating it, locking adenylate cyclase in the on state. This causes a sustained rise in intracellular cyclic AMP in the intestinal epithelial cells. The high CAM drives massive secretion of CH-L via the CFTR channel into the gut lumen, with sodium and water following, producing the voluminous, watery rice water stool and the rapid, life-threatening dehydration. The mucosa itself is not invaded, so there is no blood or pus. The correct answer is B. The mechanism. Permanent G's activation raising CAMP is shared by heat-labeled toxin of ETEC, which causes a milder traveler's diarrhea. The treatment is the key clinical pearl, aggressive oral or IV, rehydration to replace fluid and electrolytes, because the diarrhea is self-limited but the dehydration is what kills. The cholera toxin's permanent GS activation, CAMP elevation, and chloride water secretion producing rice water stool is the answer. Which mediator directly raises the hypothalamic set point, and what is the target of antipyretics like aspirin? During a bacterial infection, a patient develops a fever. A physiologist explains that pyrogens act on the hypothalamus to raise the body's thermoregulatory set point. Read the command mediator raising the set point and antipyretic target. Prostaglandin E2 raises the hypothalamic set point. Antipyretics inhibit COX. Fever is generated when the hypothalamic thermoregulatory SET point is raised. The chain is, infection triggers macrophages to release pyrogenic cytokines, IL-1, IL-6, and TNF, which act on the hypothalamus and induce the production of prostaglandin E2, PGE2. PGE2 is the final mediator that directly raises the hypothalamic set point. The body then behaves as if it is cold relative to the new higher set point, vasoconstricting and shivering to generate and conserve heat until the temperature rises to match. The correct answer is A. This is exactly where antipyretics work. Aspirin, NSAIDs, and acetaminophen inhibit CY-cyclohexygenase COX, the enzyme that makes prostaglandins, reducing PGE2 production in the hypothalamus and lowering the set point back toward normal, relieving the fever. So PGE2 is the key fever mediator, and COX inhibition is the antipyretic target. Prostaglandin E2 raising the hypothalamic set point with antipyretics inhibiting cyclooxygenase is the answer. What is the most likely diagnosis? A 52-year-old woman presents with months of fatigue and severe pruritus and is found to have jaundice. Labs, markedly elevated alkaline phosphatase and a cholestatic pattern, elevated cholesterol, and a strongly positive anti-mitochondrial antibody. Biopsy shows lymphocytic granulomatous destruction of the small intrahepatic bile ducts. Read the command, most likely diagnosis. Middle-aged woman, pruritus, cholestasis, anti-mitochondrial antibody, destruction of small intrahepatic bile ducts, primary biliary cholangitis. This is primary biliary cholangitis, formerly primary biliary cirrhosis, an autoimmune disease that destroys the small intrahepatic bile ducts. It classically affects middle-aged women and presents with fatigue and prominent PRI2s from retained bile acids, later jaundice, xanthomas from high cholesterol, and a cholestatic lab pattern with markedly elevated alkaline phosphatase. The diagnostic serologic marker is the anti-mitochondrial antibody AMA present in the great majority of cases. Biopsy shows lymphocytic granulomatous destruction of the small bile ducts. Correct answer is C. The crucial contrast is with primary sclerosing cholangitis. Choice D. PSC affects both intra and extrahepatic ducts, causing a beaded appearance on imaging, is associated with ulcerative colitis and PNK, not AMA, and is more common in MEN. So PBC is anti-mitochondrial antibody, small intrahepatic ducts, middle-aged women. PSC is PNK, large duct beading, ulcerative colitis, men. The anti-mitochondrial antibody with small intrahepatic bile duct destruction points to primary biliary cholangitis. Treat with ursodeoxycholic acid. Which structure is being compressed, and by what? A 60-year-old man with a known lung cancer presents with facial swelling and plethora, distended neck and chest wall veins, and headache that worsens when bending forward. Symptoms are worse in the morning. Read the command. Which structure and by what? Lung cancer, facial swelling, plethora, distended neck chest veins, headache worse bending forward. Superior vena cava syndrome. This is superior vena cava syndrome, obstruction of the superior vena cava, most often by an adjacent mediastinal mass, classically a lung cancer, especially small cell or squamous or lymphoma in the right upper lobe or mediastinum. The SVC drains venous blood from the head, neck, upper chest, and arms back to the heart. When it is compressed, that blood backs up, producing facial and upper body swelling and plethora, distended neck and chest wall collateral veins, and a headache from raised venous and intracranial pressure that worsens when bending forward or lying down, and in the morning. The correct answer is D. The dilated collateral veins over the chest wall and the positional headache are characteristic, reflecting the obstructed venous return, seeking alternate routes. Severe SVC syndrome with airway or cerebral compromise is an oncologic emergency. The combination of facial plethora, distended neck and chest veins, and a positional headache in a patient with a mediastinal lung cancer is superior vena cava syndrome from SVC compression. What is the analysis method and the summary statistic? A clinical trial compares survival between two cancer treatments. Some patients are still alive at the end of the study, and some drop out before it ends. These patients are censored. The results are displayed as stepwise curves of the probability of survival over time, and the relative risk of death over the follow-up is summarized as a single number. Read the command, method, and summary statistic. Survival over time with censoring, stepwise curves, relative risk of death, Kaplan-Meier analysis, hazard ratio. This is Kaplan-Meier survival analysis. It is used for time to even data, such as time until death, and it handles censoring, where patients are lost to follow-up or are still event-free at the study's end, by including them up to the point they are censored. The results are displayed as the characteristic stepwise survival curves, each step a drop when an event occurs. To compare two curves, the log-rank test assesses whether they differ. The summary measure of the relative risk of the event over the follow-up period is the Hayes-Azad ratio. The correct answer is E. The hazard ratio is analogous to a relative risk but applies continuously over the follow-up. A hazard ratio above 1 means increased risk of the event in the treatment group, below 1 means reduced risk, and 1 means no difference. Kaplan-Meier curves with the log-rank test for comparison and the hazard ratio as the summary statistic are the standard for survival data. The stepwise survival curves with censoring and the hazard ratio identify Kaplan-Meier survival analysis. Which amino acids are affected and what is the inheritance? A 25-year-old man has recurrent kidney stones. Stone analysis shows the stones are made of cysteine. Urinalysis shows hexagonal crystals. A urinary cyanide nitroprusside test is positive. The defect impairs the renal tubular reabsorption of certain amino acids. Read the command. Which amino acids and inheritance? Cysteine stones, hexagonal crystals, positive cyanide, nitroprusside, defective amino acid reabsorption, cystinuria, cola amino acids, autosomal recessive. This is cystinuria, an autosomal recessive defect in the renal and intestinal transporter that reabsorbs a group of the basic amino acids. The affected amino acids are remembered by the mnemonic cola, cysteine, ornithine, lysine, and arginine. Because the transporter cannot reabsorb them, they are lost in the urine. The clinically important one is cystine, which is poorly soluble, so it precipitates and forms recurrent kidney stones, classically with hexagonal crystals on urinalysis. The urinary cyanide nitroprusside test detects the excess cysteine. The correct answer is B. The key facts: cystinuria is autosomal recessive, affects the cola amino acids, and causes recurrent cysteine stones that are characteristically radio-opaque faintly with hexagonal crystals. Treatment focuses on cysteine solubility, hydration, urinary alkaline. Alkalinization: cysteine is more soluble at higher pHe and chelating agents like penicillamine. The CoA amino acid transport defect with hexagonal cysteine crystals inherited in an autosomal recessive pattern defines cystinuria. What is the underlying pathology? A 28-year-old woman presents with episodes of blurred vision in one eye with pain on eye movement, optic neuritis, and at another time, weakness and numbness of a leg, which have come and gone over the past 2 years. MRI shows multiple white matter lesions, including periventricular plaques, disseminated in space and time. CSF shows oligoconal bands of IgG. Read the command, underlying pathology. Young woman, optic neuritis and other neural episodes separated in time-space, periventricular plaques, oligoconal bands, multiple sclerosis, CNS demyelination. This is multiple sclerosis, an autoimmune demyelinating disease of the central nervous system. T cells attack the myelin and the oligodendrocytes that produce it, forming plaques of demyelination scattered throughout the white matter, classically in a periventricular distribution. The clinical hallmark is lesions disseminated in space and time, different neurologic deficits, at different times affecting different parts of the CNS, with relapses and remissions. Optic neuritis, painful monocular vision loss, is a classic presenting episode along with internuclear ophthalmoplegia, sensory and motor deficits, and bladder dysfunction. The correct answer is D. The diagnostic findings support central demyelination, MRI showing multiple periventricular white matter plaques, and CSF showing oligoconal bands of Ig, reflecting intrathecal antibody production. MS affects the CNS-only brain and spinal cord, distinguishing it from Guillain-Barré, which is peripheral. It is most common in young women in temperate latitudes. The autoimmune CNS demyelination with periventricular plaques and oligoconal bands is multiple sclerosis. Which set of physiologic responses correctly describes acclimatization to high altitude? A healthy mountaineer ascends rapidly to high altitude, low barometric pressure, low inspired oxygen. Over the next hours to days, his body adapts. Read the command. Which responses describe altitude acclimatization? Hyperventilation, respiratory alkalosis, increased EPO and red cell mass, increased 2003 BPG. At high altitude, the low barometric pressure means low inspired oxygen, causing hypoxemia. The body acclimatizes with several responses. First, the low oxygen stimulates the peripheral chemoreceptors to drive hyperventilation, which blows off CO2 and produces a respiratory alkalosis. Second, the chronic hypoxia stimulates the kidneys to release erythropoietin, increasing red cell mass over days to weeks to carry more oxygen. Third, red cells increase 2003 BPG, which right shifts the oxygen hemoglobin curve to enhance oxygen UN loading to the tissues. Chronic hypoxia also causes hypoxic pulmonary vasoconstriction, raising pulmonary pressures. The correct answer is B. The kidney also compensates for the respiratory alkalosis over days by excreting bicarbonate. Hypoxic pulmonary vasoconstriction, while improving local VCQ matching, raises pulmonary artery pressure, and over time can lead to right heart strain and contributes to high altitude pulmonary edema. The combination of hyperventilation with respiratory alkalosis, increased erythropoietin and red cell mass, and increased 2 or 3 BPG is the correct acclimatization response. What is the underlying immunologic mechanism of this disease? A 12-year-old boy with eczema and seasonal allergies has recurrent episodes of wheezing, chest tightness, and dyspnea triggered by exercise and cold air. During an attack, exam reveals diffuse expiratory wheezes and a prolonged expiratory phase. Sputum shows eosinophils, Kirschmann spirals, and charcoal. Leiden crystals. Read the command. Underlying immunologic mechanism. Atopic child, episodic reversible wheezing triggered by exercise cold, eosinophils, Kirschmann spirals, Charcot, Leiden crystals. Asthma, T2EE, airway inflammation. Asthma is a chronic inflammatory airway disease, and the underlying mechanism in the common allergic form is a Th2-driven IgE-mediated process. In atopic individuals, allergen exposure drives E2 helper cells to release IL-4, IL-5, and IL-13, which promote IgE production and recruit eosinophils. On re-exposure, allergen cross-links IgE on mast cells, triggering release of histamine and leukotrienes that cause bronchoconstriction, airway edema, and mucus. The result is bronchial hyperactivity and reversible bronchoconstriction, episodic wheezing, chest tightness, and a prolonged expiratory phase triggered by allergens, exercise, and cold air. The correct answer is D. The sputum findings are classic: eosinophils, Kirschmann spirals, mucus cast of the airways, and Charcot Leiden crystals breakdown products of eosinophilic findings defines asthma. The key feature distinguishing asthma from COPD is reversibility. Asthmatic obstruction reverses with bronchodilators, whereas COPD is largely fixed. The E2-driven IgE-mediated airway inflammation with reversible bronchoconstriction and eosinophilic findings. Treat with inhaled bronchodilators and corticosteroids. What is the mechanism of this drug and the cause of the neuropathy? A child with acute lymphoblastic leukemia is treated with a chemotherapy regimen including vincristine. Several weeks later, he develops tingling and numbness in the hands and feet, loss of ankle reflexes, and constipation. Read the command, mechanism, and cause of neuropathy. Vincristine, microtubule inhibition, binds tubulin, blocks spindle, axonal microtubule disruption causes peripheral neuropathy. Vincristine is a vinca alkaloid that works by binding TUB-UN and inhibiting microtubule polymerization. Microtubules form the mitotic spindle, so blocking their assembly arrests, dividing cells in metaphase, M phase, killing rapidly proliferating cancer cells. But microtubules are also essential for axonal transport in neurons. Disrupting them impairs the transport machinery of peripheral nerve axons, producing the dose-limiting peripheral neuropathy. The tingling, numbness, loss of reflexes, and autonomic effects like constipation seen here. The correct answer is C. The mechanism elegantly explains the toxicity. The same microtubule disruption that stops cancer cell division also disrupts neuronal axonal transport. Vincristine's signature toxicity is peripheral neuropathy, whereas its relative vinblastine causes more bone marrow suppression. Vinblastine blasts the bone marrow. Paclitaxel, by contrast, hyperstabilizes microtubules but also causes neuropathy. The tubulin-binding microtubule inhibition causing axonal disruption and peripheral neuropathy is vincristine's mechanism. Which organism is responsible? A 35-year-old man returns from travel with several weeks of bloody, mucoid diarrhea and lower abdominal cramping. Later, he develops right upper quadrant pain and fever, and imaging shows a single liver abscess with anchovy paste. Contents. Stool microscopy shows cysts with up to 4 nuclei and trophozoites containing ingested red blood cells. Colonic biopsy shows flask-shaped ulcers. Read the command. Which organism? Bloody mucoid diarrhea, liver abscess with anchovy paste, trophozoites with ingested RBCs, flask-shaped ulcers, Entamoeba histolytica. This is Entamoeba histolytica, a protozoan parasite acquired by ingesting cysts from fecally contaminated food or water. It causes amoebic dysentery, bloody, mucoid diarrhea with cramping, by invading the colonic mucosa, where it creates the characteristic flask-shaped ulcers, a narrow neck opening into a wide base. It can then spread hematogenously to the liver, forming an amoebic live-IV abscess, classically containing reddish-brown anchovy paste material. Microscopy shows cysts with up to 4 nuclei and trophozoites that have ingested red blood cells, a key diagnostic feature distinguishing it from non-pathogenic amoebae. The correct answer is B. The combination of bloody dysentery, flask-shaped colonic ulcers, and anchovy paste liver abscess, and trophozoites containing ingested red cells is essentially pathognomonic for Entamoeba histolytica. Contrast with Giardia, which causes a non-bloody, fatty diarrhea without invasion. Treatment is metronidazole for the invasive trophozoites plus a luminal agent like perimomycin to eradicate cysts. The invasive amoebic dysentery with flask ulcers and liver abscess is Entamoeba histolytica. Which cytokines drive each pathway, and what is the main function of each subset? An immunology student studies helper T-cell differentiation. A naive CD4 plus T-cell can differentiate into a H1 or a H2 subset depending on the cytokine environment. Read the command which cytokines drive each and their functions. IL-12-IFN, gamma, DH1, macrophage cellular, IL-4, IL-4, ID2, B-cell, IEEE allergy. A naive CD4 positive helper T-cell differentiates down one of two main pathways depending on the cytokines present. IL-12 for macrophages and dendritic cells and interferon gamma drive Th1 differentiation. 81 cells secrete interferon gamma and activate macrophages, promoting cellular immunity against intracellular pathogens, delayed type hypersensitivity, delayed type hypersensitivity. In contrast, IL-4 drives Th2 differentiation and interferon gamma drive Th1 differentiation. Two cells secrete IL-4, IL-5, and IL-4, which help B cells produce antibody, especially IgE, and orchestrate defense against parasites in the allergic response, recruiting eosinophils and mast cells. The correct answer is A. The two subsets cross-regulate. Th1's interferon gamma inhibits H2, and H2's IL-4 and EL10 inhibit Th1, so the immune response polarizes toward one arm. Th1 handles intracellular bugs via macrophage activation. Th1 handles parasites and drives allergy via IgE and eosinophils. IL-12 with interferon gamma driving H1 cellular immunity and IL-4 driving H2 humoral and allergic responses is the correct pairing. Block 17 is done. Let's review the 5 biggest traps from this block. Trap 1. Hemophilia A or B causes deep bleeding like hemarthrosis, with an isolated prolonged PTT, normal PT, and normal platelets and bleeding time, inherited X-linked recessively. Trap 2. Dysphagia to both solids and liquids from the onset signals a motility disorder. Achalasia from loss of myenteric inhibitory neurons with the bird's beak esophagus. Mechanical obstruction affects solids first. Trap 3. Primary biliary cholangitis has anti-mitochondrial antibodies, destroys small intrahepatic ducts, and affects middle-aged women. Primary sclerosing cholangitis has PANCA, beaded large ducts, ulcerative colitis, and affects men. Trap 4. The abducens nerve has the longest intracranial course, so raised intracranial pressure can cause a sixth nerve palsy, a false localizing sign. The eye cannot abduct and turns inward. Trap 5. Vincristine and vinblastine both inhibit microtubules, but vincristine's signature toxicity is peripheral neuropathy, while vinblastine suppresses the bone marrow. Vinblastine blasts the marrow. 17 blocks. 340 questions. Train process, not memorization. Step logic, learn how to think, not memorize.